and we will hopefully be posting it on GPHA's website, but I will also send out the recording once it is ready to our membership. We also welcome any guests that were invited by our epidemiology section membership. These webinar series are open to anyone that wants to join. Please stay till the end because we have an announcement for our next webinar that we will be hosting in May as well. So just to get us started, Dr. Edison is a CDC Career Epi Field Officer at Georgia Department of Public Health. I've gotten the pleasure of working with her several times, including on drug overdose surveillance. So Dr. Edison, do you want to start?
Sure. Hey, everybody, can you guys hear me? I'm going to take that as a yes. Okay. All right, so I am at the Department of Public Health. I'm overseeing the Drug Overdose Surveillance Unit. We actually just got a name. I'm going to talk to you a little bit about the drug overdose surveillance that we're doing here, and I'm going to touch on an outbreak that we responded to recently with Amber, actually, and some of the other activities going on at DPH. So feel free, if it's practical with the platform, to interrupt me if you have questions, or we can hold them till the end.
For questions, I have everyone muted during the presentation, so if you have any questions, just put them in the chat box. And then after the presentation is over, I'll unmute everyone so everyone can speak their questions. Okay,
sounds great. All right, so our efforts for overdose surveillance began in 2017. Before that, we really weren't doing anything. We gotten involved in a couple of outbreaks. One was an outbreak of illness associated with a bad batch of synthetic cannabinoids, Crazy Clown, if you remember that. And also were contacted in 2014 or 15 by a doctor at Grady who noticed an increase in overdoses and started testing for fentanyl, and we actually just published a paper on that. So we'd done a little bit of background work, but we really were doing no surveillance for overdoses. And, as you know, the epidemic was gaining in speed and in public attention, and we really needed to get going, but we didn't have any resources here to do it at the time besides me. So in 2017, we actually got some funding from CDC to begin our efforts, and we have three major activities going on at DPH. The first is an epidemiology. That's the Drug Overdose Surveillance Unit, and we are working with the data sources that we have access to and conducting surveillance for opioid dependence and also overdoses. And I say opioid, but we're really targeting our efforts to be sort of all drug because it's opioids today, but they're saying the stimulants are, making a comeback, and it could be something else tomorrow. And we also do outbreak response and planning. We are now managing the prescription drug monitoring program, which I'll refer to as the PDMP, and I'm going to talk about that a little bit. And we've also been tasked with writing a statewide strategic plan, coordinating with various stakeholders across the state to make that happen. And I'll touch briefly on that effort as well. All right. So just a teeny bit of background. I know you all have probably heard a lot about it, but in 2016, over 42,000 people died of an opioid overdose, and over 15,000 people of a heroin overdose. Those numbers are likely underreported. From 2000 to 2016, opioid overdose deaths increased 5 times, and there were over 600,000 people who died from drug overdoses during that period. That's about 115 deaths per day. If you think about this in terms of a disease outbreak, it would be really scary. So I think it's finally getting the attention it deserves. Prescription opioids are a driving factor. Prescription opioid sales quadrupled from 1999 to 2010, despite reports that people's perceived pain is not any worse. So I really think that this epidemic has been driven by prescribing practices. So anyway, we are tasked with trying to understand the scope of the problem here in Georgia. So how do we go about doing that? As you all know, I'm preaching to the choir here, the success of any disease prevention or containment strategy is founded upon epidemiology and surveillance. But it's really hard to do, particularly for something like this. One of the things we really have no way of getting at is how many people are at risk of addiction and overdose and death. And all the data sources we have give a small snapshot of the problem, but they all have a lot of limitations. Despite that, we're using the data we do have to describe the extent of the epidemic and really look at trends and hotspots. Use that information to inform our partners so that they can direct their prevention and treatment and enforcement and policy decisions to attack this epidemic. You know, we really provide information, but we don't do a lot of the programmatic work at DPH, at least at this time. So opioid overdose surveillance, as I mentioned, we got CDC grant funding to initiate this. We are funded under 2 different grants, the Data-Driven Prevention Initiative, which is focusing on the PDMP and strategic planning, and then the Enhanced Surveillance for Opioid Overdoses for States. It's called ESOS. We call it SOS over here. We received that funding in September. So with this funding, we've been assembling a team of epidemiologists and information technologists to improve our surveillance. Our goals are to create overdose data reports and respond to data requests from partners across the state. The picture on the right is a snapshot of the preliminary overdose surveillance report that we put out in December, which is available on the DPH website. The link is at the bottom. We are working to identify and respond to overdose clusters and to create an electronic overdose module that can help us integrate data sources and will eventually create visual displays and easier data access both for our epidemiologists in districts and at the state, but also eventually for the public. So I'm going to talk here about our data sources that we're using currently. The first is hospital and emergency department discharge data. This is ICD-10 coded and received quarterly from all Georgia hospitals. It does give us a good picture of how the opioid epidemic is affecting the healthcare system. You, as epidemiologists, probably all know the limitations of ICD-10 coding. It can, you know, it's not very sensitive or specific. There's a lot of variation in how people code things. So we definitely have limitations, but we at least can be looking at trends. We are looking both at sort of acute overdoses and also beginning to look at opioid dependence in these data. We use syndromic surveillance data. So currently we get a daily feed of emergency department visits, and we are working on incorporating EMS trip reports as well. And we use it to rapidly identify clusters and trends. And I'll show you a picture of how we use that in a previous outbreak. So we do monitor that on a daily and weekly basis, looking for any increases in, in regions across the state. NAS reports. NAS is neonatal abstinence syndrome. That's when a baby is born with drugs on board and has to go through withdrawal. It could be from alcohol, marijuana, cocaine, opioids. It is a reportable condition in Georgia as of 2016, and they're getting to the point where most hospitals are now reporting. They report directly into SENS, and there is an NAS report available for 2016 on the DPH website as well. We have the PDMP data. I'm going to talk a little bit more about that in a minute. We have death data. We have that through a couple means. The most common one that we use is death certificates. The problem that we have with our death data is that it's not timely, in part because the toxicology testing can take a long time, and we find that on average, overdose deaths are being reported at about 60 days after the death, but they even go out to like 9-10 months. If there's a criminal investigation pending, then they often won't actually report that death in a timely manner. So we've been working on ways to improve the timeliness of this reporting. One of the things that we've done is we've actually added a checkbox to the electronic vital record system. It's currently in the test system where people can indicate if they have reason to suspect a death is related to a drug overdose, an unintentional drug overdose. And we're hoping that that can help improve timeliness of reporting even before toxicology is done. We're also expanding the Georgia Violent Death Reporting System to include drug overdose deaths. So we've just started receiving reports from medical examiners and coroners about these overdose deaths, including the toxicology, and we're starting to abstract this more detailed information about these deaths. So hopefully we'll be able to have a better understanding of them soon. We have access to drug seizure data from the Georgia Bureau of Investigation's GBI, and that can give us an idea of the trends that they're seeing. And these drug seizures tend to be when somebody is arrested, if there is, or even sometimes if somebody just is sent off to the hospital and the police get involved, they may seize drugs on the scene and get those tested. Another data source that we're getting close to being able to use is called ODMAP. This is a new data source. It's actually an app for handheld devices that first responders can use. And it doesn't have identifiable information, but it GPS marks where they are when they respond to an overdose, and they can say if naloxone was administered and if the person lived or died. It will be used sort of as syndromic surveillance, but it's being rolled out slowly across the state, jurisdiction by jurisdiction. So there are actually some jurisdictions up and running, but we have a long way to go before it will be representative of the state. And then last, we have behavioral survey data, and we're in the process of trying to identify funds right now to add drug behavioral questions to BRFIS. All right. So in Georgia, I'm going to present some data from our 2016 report. And these data come from hospital discharge data and vital records death certificates. Our case definition for hospital discharge data was quite narrow. We were really trying to get at acute overdoses, so not really looking at the issue of dependence. We searched on only the primary diagnosis when doing this. And we didn't use any of the dependence codes. Just of interest, when we expand our definition, which we will be doing in our reports, to look at more than the primary diagnosis and to look at dependence codes, these numbers actually quadruple. So we really think this is one slice of the problem, these acute overdoses, but it's really the tip of the iceberg when looking at the full problem of opioid dependence. So this is a graph of opioid overdose deaths by drug type and year. You can see all of these lines, have a steady increase. The top line is a death that had any opioid on board. The gray line is heroin, and the peach-colored line is fentanyl. So from 2010 to 2016, opioid overdoses increased by 170%. That's from 426 to 929 deaths. Beginning in 2013, you can see the bottom two lines really start increasing, indicating to us that illicit opioids really drove the sharp increase. Presumably what happened is prescribing, increased. People get addicted to prescription opioids, and then when it's harder for them to get them and expensive for them to get them, they'd move over to street drugs, which is where we're seeing the heroin and the fentanyl. And in 2016, fentanyl-involved deaths actually approached the number of heroin-involved deaths. So fentanyl's really creeped into the illicit drug supply. This is a chart of overdose deaths by drug type from 2016. All drugs could include any prescription or illicit drug. Then we have 929 opioids. Any opioid, 231 heroin deaths, and 199 fentanyl deaths. This is the death rate by race and drug type. So whites were 4.2 times more likely to die from an opioid-involved overdose than blacks, and that ratio held about the same for heroin as well. But when we change what we're looking at and we look at sex by drug type, we see quite a difference. Males were 1.6 times more likely to die from any opioid than females, but 4.1 times more likely to die from a heroin-involved overdose than females. So it appears that men are transitioning to street drugs more frequently than women. This now looks by age and sex. You can see the lines all increase in sort of the 25 to 34 is the most common age, but particularly for young males. Males aged 25 to 34 years died from an opioid-involved overdose more frequently than persons of any other age category, and were 2.1 times more likely to die from an overdose than females of the same age. Interestingly, when you look at 45 to 54, females actually surpass males. All right, so now we're transitioning over to morbidity or data, and these are emergency department and visits and hospitalizations. The darker line is emergency department visits, and the peach-colored line is hospitalizations. Important to note that in this data source, anybody who is admitted to the hospital from the emergency department only appears in the hospitalizations. So there actually were more emergency department visits than appears in these data. They just ended up being hospitalized as well. So in 2016, there were 2,435 opioid-involved overdose visits and 929 hospitalizations, and 849 heroin-involved overdose visits and 251 hospitalizations. As I mentioned before, when we look beyond the primary diagnosis code and we use the drug dependence ICD codes, these numbers actually quadruple. All right, so the top graph is looking at emergency department visits, and the bottom graph is looking at hospitalizations. And this is by drug type and age. In the top graph, you can see that the most common age to visit an emergency department visit, either for a heroin or opioid overdose, is in the 25 to 34 year age category. But in the bottom graph, you see that people are most hospitalized for an opioid overdose in the 65 to 74 year age category. And heroin was very uncommon in both young and old populations. All right, so now for a couple maps. It's important to note here that this is a map of counts. So actually the number, not the rate, but the number of emergency department visits and hospitalizations due to a heroin-involved overdose. If you're familiar with the map of Georgia, you'll know that these are primarily focused on urban areas. Can you guys see my mouse? I'm not sure if you can see the mouse, but we've got the Atlanta metropolitan area, we've got Augusta, Macon, Columbus, and Savannah, and then a little blip up in Gilmer County in north central Georgia. But now we're going to change what we're looking at. We've gone from heroin to any opioid, and we've expanded out from counts to rates. And you can see the map lights up in a whole bunch of different places. North Georgia, some rural counties are very heavily affected, and southeast Georgia, some rural counties as well. So while these counties may not have the high numbers that the urban areas do, the rates are high, indicating that the opioid epidemic is really having a heavy impact on these communities. So some additional resources coming soon. We're going to expand our 2016 surveillance report and produce a 2017 surveillance report. Those should be available by August of this year. They do have county-level data, so you can see what's going on in your jurisdictions. We are going to expand beyond this acute overdose to look at dependence as well. We are also going to include drug seizure data in that report, and we are going to be producing a 2016 and 2017 PDMP report, and we will soon have a drug overdose surveillance unit website where you will be able to have easy access to all these and also some other good surveillance resources as well. The 2016 NAS surveillance report is available on the DPH website. And OASIS now has drug overdose death query tool. This is a picture of it. If you just search DPH OASIS, it'll come up. You can drop down the menu and look, kind of boil down into different types of opioids. You can look by county. You can look at numbers and rates, and you can look over years as well. Currently, OASIS is actually using a different case definition for these deaths than we are, but we're working on coordinating our efforts. But it's still a great tool to see what's happening in your area, and it does show trends, which is really nice as well. And we're hoping to have the hospital discharge data added to this sometime soon as well. All right, so another thing in EPI we're tasked with is doing some outbreak response planning. Oh, PAN, sorry. I just noticed it should say plan. We are working to develop a plan to respond to possible clusters that might be identified through syndromic surveillance, and also confirm clusters of illness that might be related to drug overdose and misuse. These can either come from syndromic surveillance and then be verified by contacting hospitals and doing some record reviews. They may come directly from the poison center or hospitals or law enforcement or even medical examiners and coroners. So our plan includes epidemiology and surveillance guidance for the state and district epidemiologists. It includes protocols for communicating with partners and also draft communication materials to share with a wide variety of partners, including the media. That plan is currently in review and hopefully will be shared with the districts very soon. We are also participating in an effort for an infectious disease outbreak response plan. We're planning for an outbreak of infectious disease, primarily HIV, hepatitis, and STDs among people who inject drugs, similar to the large outbreak of HIV in Indiana among injection drug users. We're coordinating across programs and diverse state partners to determine the surveillance and the response activities. So surveillance is as being done in any outbreak, but there's a lot of other activities that will include testing among high-risk persons, linkage to care that might be HIV, hepatitis, STD care, and also drug treatment programs, pre-exposure prophylaxis, and for HIV, potentially vaccination for hepatitis. Harm reduction would be a part of this outbreak response as well, such as syringe services programs. Unfortunately, the needle exchange bill did not pass the legislature, so it's still not legal in Georgia, but we think if we were having an outbreak, we might be able to find a way around that, and we're hoping it will pass next year. All right, so now I'm going to talk briefly about an outbreak that we responded to in Macon last June. Our outbreak response planning really hinged on the lessons learned from this. We had never really responded to an outbreak like this prior to this. So we muddled our way through it a little bit, but I think we did a good job and we've learned a lot from the process. So in on June 6th of last year, Navicent Healthcare in Macon notified the Georgia Poison Center of 6 overdoses and 1 death in the previous 24 hours. It was an astute clinician that noticed this was happening, and he noticed that patients were coming in with severe respiratory depression, requiring large doses of naloxone, and many were placed on a ventilator. And they reported buying Percocet on the street and only taking 1 or 2 pills to have a very big effect. So Georgia Poison Center contacted the other area hospitals to ask them to look for additional cases, and the Poison Center also notified Epidemiology at DPH. So DPH, we undertook notifying a bunch of partners so they could be on the lookout and know what was going on. We notified the local health districts, the Georgia Bureau of Investigation, and the other medical examiners in the area, and also the Macon-Bibb Coroner's Office. We notified the Georgia Drug and Narcotics Agency, the High Intensity Drug Trafficking Area Office. That's a federally funded program that conducts really their law enforcement. They do a lot of drug surveillance in the area, and they work closely with law enforcement across the state. And through them, we reached out to law enforcement and also used the Georgia Fusion Center, otherwise known as GSAC, to reach law enforcement across the state. We reached out to the Department of Justice. Their U.S. Attorney in the Atlanta area has been very involved with drug overdose efforts and trying to pull coalitions together to combat the epidemic. The Office of EMS and the Georgia Regional Healthcare Coalitions, and we also provide notification and guidance to all Georgia doctors. This notification was sent out very quickly, notifying it goes out to, by email to all registered doctors in Georgia or licensed doctors, and it just mentioned what was happening and that doctors should be on the lookout for cases, how to protect themselves if they came into contact with the drugs, and how to notify public health. So we had to create a case definition so that we could try to weed out the background overdoses that occur every day across the state from cases that might be associated with this cluster. Our case definition ended up being patients that present on or after June 1st with an opioid toxidrome requiring resuscitation, ventilation, and or naloxone for reversal of symptoms. Toxidrome is a term that I learned when we started to get involved in this effort, and it is a cluster of symptoms that are indicative of a specific toxic exposure. So with opioids, it tends to be respiratory, cardiovascular, and CNS depression. So they also had to have an exposure history that may involve purchasing pills off the street or a similar story, an exposure history that may involve the ingestion of a small quantity of the suspect pills resulting in big symptoms. So, for example, ingestion of 1 or 2 pills producing sudden onset of CNS, respiratory, or cardiovascular depression. And along with this case definition, we provided guidance about what to do if a pill was found to protect first responders. And the importance of that is that fentanyl, the drug that tends to cause these dramatic effects, it can be absorbed transdermally or can be inhaled if it's, if it's a powder and aerosolized. And there have been quite a few instances across the country of first responders overdosing just from coming into contact with this drug. So media were really important partners in getting the word out here. Within a few hours of notification, there were 2 press conferences. One was held by the hospital and the Macon-Bibb Sheriff Office, and another was held here in Atlanta, and it was a joint effort between the Georgia Poison Center, DPH, Georgia Bureau of Investigation, and the Department of Behavioral Health and Developmental Disabilities, or DBHDD. We provided daily media updates. It actually got national media attention, and the GBI released preliminary and confirmed reports on the testing of pills that they obtained. One of the challenges we had with the media is that the media always wanted to know how many, and it's really hard to say how many. These reports that we got in, many of them turned out not to be cases. Upon further review, it turns out they had overdosed perhaps on an opioid but not related to this cluster. Our information was based on reports either by the drug user, who is a population that might lie about what they took, or by people who came in with them who may or may not know what they took. So it can be really hard to truly determine if a case is related. Okay, whoops, sorry. So case finding, how do you confirm if an overdose is associated? We asked area hospitals to report cases through the Georgia Poison Center. We partnered with them on this because if they did have an overdose coming in, we weren't really in a position to advise on treatment, but the Poison Center was. And then they sent cases over to us. We asked the Office of EMS to ask their services to report suspect transports that might be related, and they sent us over a daily line list. The district EPI reached out to the area hospitals for a list of suspect cases and performed medical record reviews. And after doing this, we had 4 unconfirmed deaths and up to 30 unconfirmed cases, but we knew those numbers would drop once we really got in and reviewed the records and performed some lab testing. So after applying our case definition to these and our district deputies very diligently reviewing all these medical records, we ended up with 27 cases and 1 death that met the case definition. Now, some of these cases were ruled out just because we didn't have enough information to make a determination. So likely there were more cases, but this is what we were able to identify. 59% were male and 70% were Black. If you remember from the charts I showed earlier, it tends to be that whites are overrepresented, and this was a slightly different population. Anecdotally, a lot of these people were people who were on pain medications for legitimate reasons, but for whatever reason had run out of their pills or needed to bridge a gap and bought some pills on the street, and all it took was 1 pill to overdose. The median age was 34 years with a range of 19 to 69. 93% had loss of consciousness, 81% respiratory distress, 37% pinpoint pupils, and 22% cardiac abnormalities. They almost all received naloxone, and 41% required intubation and mechanical ventilation, and almost 60% had multi-drug positive urine drug screens. But interesting to note that this drug does not show up on routine urine drug screens. and requires special testing. All right, so lab testing, the GBI, actually local law enforcement was able to obtain a couple pills, and they got them tested at the GBI lab. And they found U47700, which is a synthetic opioid, and cyclopropylfentanyl. Both of these are many times stronger than heroin and really deadly opioids. They did actually perform some testing for us on patient specimens, on patients that did not die. They don't usually do this, but they did in this case, and most of the cases also had these same drugs on board. All right, so we also work closely with law enforcement. As I mentioned before, we communicated through GSAC, HIDA, and the GBI. Local law enforcement took the suspect's pills and patient specimens to the GBI lab for testing. We continue to work on ways to improve our two-way communications between public health and law enforcement. I feel like we're pretty good at pushing the word out to law enforcement, but they're not that great at getting the word back to us about what's going on. So we're working on improving that. We know that messaging to law enforcement has to include responder safety and naloxone and PPE, so how to protect themselves if they come into contact with it, how they can get naloxone if they're not provided with it from their, through their work, that there's a naloxone standing order and anybody can buy naloxone in any pharmacy without a prescription. And the Georgia medical amnesty law is also important to get the word out about that. Anyone calling 911 cannot be persecuted by the law because they've been using drugs if they're calling to report an illness. So one thing that we found really interesting is that while the naloxone standing order had been in Georgia for quite a while at this point, many responders and even pharmacies didn't know about the standing order. So we've been working on sending communications to pharmacies, fire, and law enforcement to notify them of the standing order and trying to get the word out to the public as well. If somebody, has an opioid user in their household, it, would behoove them to have naloxone on hand in the event of an overdose. So this is a map of syndromic surveillance for the Macon district during this period. This came to light because a very astute clinician noticed that there was a cluster happening in their emergency department. When the Poison Center reached out to other area hospitals, their initial response was, no, we haven't seen anything. But then one of them, upon further review, realized that they'd had 10 cases over the last couple days. This is due in part to the way emergency department works. They are triaged in and then seen by different doctors, and there's not necessarily oversight over the patient load at any given time, so it easily can be missed that there is something happening. As happened in that situation. So if the doctor hadn't picked it up, we're hopeful that we would have identified this through our syndromic surveillance. The red line was the day that they all started coming in, and it showed it very clearly. So lessons learned from this, clusters are not easy to identify. I just mentioned that, one of the emergency departments actually missed that this was going on. And it's also very difficult to confirm if cases are associated. Syndromic surveillance may help us identify clusters in the future, and quick identification and notification matters. This outbreak dropped off very quickly. I like to think it was because we got the word out on the street, and hopefully, there was a lot of local media attention, and I'm hoping people saw this on their local news and didn't take the pills if they had them in possession. And communication and collaboration is key. We've, because of this, been working to develop protocols to improve communications and making sure that messaging improves responder safety so that first responders don't get themselves in trouble if they come into contact with these drugs. All right, so now I'm going to transition over to the Prescription Drug Monitoring Program, or PDMP. The PDMP was established in 2011 by the Georgia legislature. And all Georgia licensed dispensers tend to be pharmacies, are required to submit information for Schedule 2 to 5 controlled substances on a weekly basis. The purpose of this is to reduce abuse of controlled substances, ensure legitimate use of controlled substances to treat pain and terminal illness, and also reduce duplicative prescribing and overprescribing. So when this was first developed, the database was run by the Georgia Drug and Narcotics Agency. but in 2017, the legislature passed a bill moving it over to the Department of Public Health. So in July of last year, we began administration of this database, and the bill also required that dispensers report within dispensed opioids, or I guess all controlled substances, within 24 hours of dispensing the drug. As of January of this year, all prescribers, so physicians, it might be nurse prescribers, it might be anybody who is able to prescribe a controlled substance, had to register with the PDMP. I think we're up to about close to 90% of all people in Georgia with a DEA license are now registered. And as of July of this year, they will have to check the PDMP for any patient before prescribing an opioid, cocaine derivative in the Schedule II category of drugs, or benzodiazepines. So they're going to have to look and see, check their prescribing history for this patient to make sure that they are not going to be overprescribing drugs. So why is this important? First of all, we have rapid reporting within 24 hours now, so we really can see what's being dispensed across the state. It tracks dispensed narcotics by patient and prescriber and provides 2 years of prescription records for every practitioner. So this can help indicate when patients have visited multiple prescribers or pharmacies or have multiple active prescriptions, and can help prescribers with their medical treatment program for pain patients. It also can assist law enforcement officers in criminal investigations of prescriber abusers or patients who doctor shop. And it can provide data that can help us assess the impact of the opioid epidemic in Georgia. So we can get some data about the number of patients receiving opioids, the number of prescriptions, the opioid type, strength, the number of doses, so we can try to assess appropriate prescribing here in Georgia. PDMPs are happening all across the country. All states have a statewide PDMP except Missouri. They actually have sort of a jurisdictional PDMP. And the software vendor that we use is called Apris Health, and they provide the platform for 42 of the states currently. There's always challenges with software vendors, but the nice thing about this is that it makes it easier to share data across states. Because, as you know, this epidemic is not confined to state lines. So we are working on improving the PDMP. We are beginning to send out clinical alerts. So if a prescriber has prescribed a pill, or, a prescription for a patient that has more than 5 prescribers or 5 dispensers in 90 days, it's called the 5-5-90 rule, they will get a clinical alert about this patient, or if they go in to check the database, an alert will pop up as well. It also can help identify active overlapping opioid and benzodiazepine prescriptions. Those two in combination are a big overdose risk because they both cause respiratory depression and cardiovascular depression. There was a bill passed this year that removes requirement for unlicensed delegates to register with the BARDA pharmacy. What this means is that doctors can have, I think it's up to 2 people that can actually go in and check the PDMP for them. One of the doctor's complaints is that they're very busy and it's hard for them to do this, so they can have a couple people register with the PDMP and do this for them. It also allows, this new bill allows DPH to share our information with electronic health records. There are some hospitals that are combining these data into their health record to make it easier for doctors to check. We can share it with other states, and including law enforcement from other states through subpoenas. We are conducting online prescriber training, system reliability testing, and ongoing outreach. There are now requirements for prescribing continuing education for doctors. And again, the mandatory first check will be July 1st of 2018, where prescribers will have to check the PDMP before writing a prescription. In states that have done this, they have seen prescribing practices really improve. Some preliminary data from the analysis we've done has some very good news finally. This table shows the number of prescriptions, the number of patients opioids were prescribed for, and the doses dispensed for 2016 to 2017. Some of these numbers are really remarkable to me. In 2016, there were 9,219,000 opioid prescriptions. That's just a huge number. But the good news is that we've seen a reduction in these in all of these indicators from 2016 to 2017. And this is probably an underrepresentation because we think that reporting in the system actually improved in 2017. So when we first looked at this, was sort of expecting to see it increase because of improved reporting, but the numbers are decreasing. So I think we legitimately have improved prescribing practices. All right, strategic planning. So one of our CDC grant-funded activities is to develop a statewide strategic plan, not just for DPH, but for the entire state. It's a tall order. There's a lot of components to combating this epidemic. In December 2017, we held a statewide planning meeting attended by over 200 diverse stakeholders from across the state. And we have ongoing work groups tasked with developing the plan. These work groups include data and surveillance, control and enforcement, prevention and education, treatment, and the PDMP. And there's also policy recommendations within each of these. The goal is to have a draft of this plan by this summer that will be presented to the governor. This is just a map. I'm not going to go into any detail about this, but it talks about the 5 different working groups, sort of pillars of planning that we have, and some of the various activities that might be included underneath these. And, you know, ultimately this involves thousands of partners to really implement this plan. I am part of the data and surveillance planning effort, and our goals in that group that we've come up with and are now working on trying to implement are first to develop a data and surveillance oversight committee. If any of you want to be on that, let me know. To identify, understand, and define relevant data. And to do that, we're going to be developing a public-facing data inventory, looking at all the different data sources that touch on this, how we access them, the rules that govern access, what can be done with them, what's being done with them. We are going to be developing a data needs assessment, and we'll be querying stakeholders to find out what they need to know from the data in order to inform their programs. And then we'll be determining how to operationalize the data and surveillance infrastructure across the state and actually make it happen. So if you want to be involved with this planning effort, please reach out to me. And that is all I have. That's just a brief overview of what we're doing. It's changing and evolving all the time. We've got a lot more data that will be coming your way soon, and we're happy to respond to data requests and also any questions you may have. So I'll now open it up for questions.
Okay, so everyone should be unmuted now. So if you have any questions, please feel free to speak up or type in the chat box. Rose, I think you're speaking, but we can't hear you. I'm not.
Well, if there's no questions, my contact information is here. I'm happy to answer questions.
Okay. All right. So thank you, Laura, for talking to us today. I don't see any questions, at least can't hear any. So I just wanted to do a quick announcement. On May 22nd, we'll be hosting our next webinar, and Melissa Hunter, the Epi and STD Program Director in the Rome Health District, and Hope Dishman, our Outbreak Coordinator at the Georgia Department of Public Health, will be talking about an outbreak involving salmonella and a holiday dinner called Foul Play Holiday. I hope you all will join us, and I'll send out the webinar information as we get closer to the dates. Thank you all for joining us today, and look forward to speaking to you later on. If you have any suggestions for webinars, please get those suggestions to either myself, Jessica Pavlik, or Christina Lai. Thank you.